مرحبا، أنا دكتورة يارا كتانة وراح نحكي اليوم عن الأسوفيجيال disorders وراح نبلش مع الجاسترو-esophageal reflux disease which is the commonest esophageal disorder. Gastroesophageal reflux disease affects 15 to 30% in Western countries of the population in the Western countries and 5 to 10% of the population in Asia. But most of these patients have a non-erosive esophagitis because erosive esophagitis accounts only to 30 to 40% of the gastroesophageal reflux disease population. Most patients have typical symptoms like heartburn, regurgitation, and dysphagia, but some patients have atypical presentation like chest pain, chronic cough, hoarseness, wheezing, and infrequently nausea. Some have water brush global sensation or odynophagia. It's worth mentioning that chest pain caused by gastroesophageal reflux can be very similar to the cardiac chest pain. It can be substernal, can be squeezing in nature, can radiate to the back, arm, neck, or jaw. The pain usually occurs after meals, can awaken the patient from sleep. It can last minutes to hours. It can also be exacerbated by emotional stress and resolve spontaneously or with antacids. The pathophysiology is always multifactorial. Most patients have gastroesophageal junction incompetence caused by increased frequency of transient lower esophageal sphincter relaxations or hypotensive lower esophageal sphincter, either caused by food like fat, chocolate, caffeine, alcohol, smoking, and drugs like anticholinergics, nitrates, calcium channel blocker, TCAs, antidepressants, as TCAs, opioids, and diazepam. Sometimes there is an anatomic disruption of the gastroesophageal junction, like patients with hiatal hernia or patients with increased intra-abdominal pressure, like pregnant patients and patients with massive ascites. Sometimes there is an impaired esophageal acid clearance caused by impaired motility or diminished salivation. Sometimes you have both of them in gastroesophageal junction incompetence associated with impaired esophageal acid clearance. H. pylori has nothing to do with reflux. It may actually be protective against gastroesophageal reflux disease, so we should not test for H. pylori in patients with typical reflux symptoms. The diagnosis sometimes in patients with typical symptoms, we diagnose based on clinical symptoms alone. In some patients, we need an upper endoscopy, especially if there are alarm features like weight loss, anemia, hematemesis, blood and stool, strong family history for cancer, GI cancer, or if they have a risk factor for Barrett esophagus, and we'll talk about that later. Esophageal manometry can be used in patients with chest pain and or dysphagia when we suspect reflux but we see a normal upper endoscopy. We do the manometry to exclude an esophageal motility disorder, which can have very similar symptoms to the gastroesophageal reflux disease. In patients with persistent symptoms, especially those who do not respond to twice daily PPI, we do an ambulatory pH or pH impedance monitoring to assess the adequacy of treatment and confirm that the patient have actually gastroesophageal reflux. Treatment, we start with behavioral changes, the most important of which are weight loss, avoid late meals, and lift lateral decubitus with elevation of the head of the bed. For mild symptoms, we can use antacids, alginates, H2 blocker. More severe symptoms need PPI once daily mostly, but we can give PPI twice daily. We give them 30 to 60 minutes before breakfast, and the surgical treatment is fundoplications, which is reserved for patients who are young, sometimes PPI dependent, or have hiatal hernia. Barrett esophagus is a complication of gastroesophageal reflux disease, and it predisposes to adenocarcinoma of the esophagus. Barrett esophagus is defined as having A metaplastic columnar epithelium that has both gastric and intestinal features that replaces the stratified squamous epithelium that normally lines the esophagus. Here is the stratified squamous epithelium, and here is the buried mucosa. Should we screen every patient with reflux for the presence of buried esophagus? The answer is no. Only patients with at least 3 risk factors for adenocarcinoma should be screened for the presence of buried esophagus. And these risk factors are hiatal hernia, older age, male sex, chronic gastroesophageal reflux disease, white individual, obesity, smoking, family history, or confirmed family history for esophageal adenocarcinoma or Barrett esophagus. The management of Barrett, we treat the cause, which is the gastroesophageal reflux disease. We do surveillance for dysplasia, also we do an upper endoscopy every 2 to 3 years, and if we find dysplasia seen by biopsies, we should treat either with ablation, with or without resection. We go to eosinophilic esophagitis, which is a relatively new disease. The first cases of eosinophilic esophagitis were described in 1970s. It is an emerging chronic type 2 allergic inflammatory disease. It is increasing in incidence and prevalence in both children and adults. Most patients with eosinophilic esophagitis suffer from dysphagia, episodes of food impaction, chest pain, sometimes gastroesophageal reflux disease-like symptoms which are refractory to antacids, rarely abdominal pain and regurgitation. Endoscopy, sometimes we see these circular rings. We call that trachealization of the esophagus because the esophagus looks like the trachea with these circular rings. Stricture, partially proximal, particularly proximal strictures like here, linear furrows as we see here in this photo, whitish speck representing eosinophilic microabscesses, and small caliber esophagus. But these findings are found only in 15 to 48% of patients with eosinophilic esophagitis. That's why we need random esophageal biopsies to confirm or exclude the diagnosis. Treatment: there is a dietary therapy which involves avoiding 6 food, which are wheat, milk, eggs, soy, nuts, and fish, shellfish. The problem with this therapy is that it's very difficult to do. Patients are mostly non-compliant because there are many important food they have to avoid, like wheat, milk, and eggs. Mostly we use topical glucocorticoid therapy like swallowed fluticasone and budesonide. We can use PPI with low response rate, and in patients who have strictures, we use endoscopic dilatation. Caustic ingestion: there is a difference between alkali and acids. Alkali typically damage the esophagus. Acids typically cause more severe gastric injury. Sometimes there is an associated laryngeal and tracheobronchial injury caused by aspiration of either acid or alkali, may cause severe ulceration, can cause bleeding, and end up with fibrosis and stricture formation. Some patients, they have to come regularly for esophageal dilatation after caustic ingestion lifelong. The risk of esophageal squamous cell carcinoma is dramatically increased in patients after caustic injury. It is estimated that up to 30% of patients with caustic injury develop esophageal cancer. We go to Zinker diverticulum, which is a sac-like outpouching of the mucosa and submucosa through a weak area which is called Killian triangle between the transverse fiber of cricopharyngeus muscle and the oblique fibers of the lower inferior constrictor. It occurs in the posterior hypopharyngeal wall. It is a false diverticular because it does not involve the muscularis propria. It contains only the mucosa and submucosa. When it's asymptomatic and small, we don't treat When it's symptomatic and large, we treat surgically at either an open or transoral approach. Esophageal web, as you see in this photo, are thin eccentric membrane that protrudes into the esophageal lumen. The pathogenesis is unknown, but sometimes it occurs in combination with other situation or other conditions like iron deficiency, anemia, and dysphagia. And when esophageal web comes with iron deficiency and dysphagia, we call this Plummer-Vinson syndrome or Patterson-Brown-Kelly syndrome. Most commonly occur in the cervical esophagus. They usually rupture during diagnostic upper endoscopy as the endoscope traverses the web. However, in patients where there is a partial disruption, we use esophageal dilatation as a treatment. Esophageal rings, they are thicker, they are concentric, circular diaphragm of tissue that protrude into the esophageal lumen. They are typically located in the distal esophagus. Schatzki ring is most common type of esophageal ring, is a narrow mucosal ring that is less than 12.5 millimeter in diameter. The pathogenesis is not clear, but gastroesophageal reflux, congenital or developmental origin have all been proposed. Most patients are asymptomatic. When patients have symptoms, they have dysphagia to solids, especially hard solids, and we treat them with dilatation. Hiatal hernia are classified into type 1, which is a sliding hernia where the gastroesophageal junction is displaced above the diaphragm, but the stomach alignment remains normal and the fundus remains under the diaphragm. Where the paraesophageal hernia, it is a true hernia with a hernia sac composed of peritoneum, and it is an upward dislocation of the gastric fundus through a focal defect in the pharyngoesophageal membrane. Symptoms of hiatal hernia are those of gastroesophageal reflux disease, but it can cause epigastric, substernal pain or fullness, nausea, or vomiting. Sometimes hiatal um, hiatal hernias are asymptomatic and found incidentally on an upper endoscopy, manometry, or imaging. Mallory-Weiss tear, it is a single longitudinal mucosal tear at the gastroesophageal junction. As you see in this photo, they heal very fast. That's why sometimes we don't find them if we do the endoscopy the second day after the admission. It causes hematemesis and should be suspected in patients with hematemesis after a history of vomiting or retching. Achalasia. Achalasia is a progressive degenerative disease causing degeneration of ganglion cells in the mentoric plexus in the esophageal wall. It causes failure of relaxation of the lower esophageal sphincter accompanied by defective peristalsis in the distal esophagus. We should also always differentiate between achalasia and pseudoachalasia, which is caused by malignancy. Malignancy can cause pseudoachalasia by invading the esophageal neural plexus directly or through the release of humoral factors that disrupt esophageal function as part of neoplastic syndrome. And patients with pseudoachalasia, they have similar symptoms and similar manometric findings as those with achalasia and can be differentiated by an upper endoscopy or endoscopic ultrasound. Clinical manifestation as expected, dysphagia, regurgitation, difficulty belching, substernal chest pain, and heartburn. There are three subtypes of achalasia according to the peristalsis in the distal esophagus. All types have failure of relaxation of the lower esophageal sphincter. And in the classic achalasias, the patients do not have significant peristaltic in the lower esophagus. They have 100% failed peristalsis. In type 2, there is also failure of relaxation of the lower esophageal sphincter associated with simultaneous pressurization that span the entire length of the esophagus. Type 3, there is premature and often lumen obliterating contraction or spasm. And we can see that in these photos. This is a high resolution manometry. In type 1, you don't have really significant peristalsis. Here you have simultaneous pressurization in the whole esophagus, and here you have premature contraction in the lower esophagus. Barium swallow in achalasia can show dilatation of the esophagus, can show narrow esophagogastric junction, can have aperistalsis and delayed emptying of barium. In the endoscopy, we see sometimes a dilated esophagus that contains residual material, and the appearance of the lower esophageal sphincter may range from normal to thickened muscular ring with rosette configuration on retroflexed view. But this appeared stenosis in achalasia is usually easily traversed with gentle pressure on the endoscope, in contrast to stenosis caused by a neoplasm or fibrotic stricture, where we cannot really traverse the area even with pressure. Treatment, the goal of treatment is to decrease the lower esophageal sphincter pressure and causing by mechanical disruption of the muscle fiber of the lower esophageal sphincter, either by balloon dilatation or by peroral endoscopic myotomy or by Heller's myotomy. Or we can use pharmacological reduction of the lower esophageal sphincter like botulism or botulinum toxin injection, oral nitrates, and calcium channel blocker. Distal esophageal spasm and hypercontractile esophagus is defined as having premature and rapidly propagated contraction in the distal esophagus. Um, in the setting of normal relaxation of the esophagogastric junction, in contrast to um, achalasia, where you have a failure of relaxation of the esophagogastric junction. It is associated with bolus retention, causing dysphagia and chest pain. It is a dysfunction of nitrinergic enteric neural innervation of the smooth muscle portion of the esophagus. Sometimes esophageal spasm can be induced by esophageal acid exposure or chronic opioid use. In the barium swallow, we can see like a rosary beard or corkscrew appearance. Schachhamel or nutcracker esophagus is a distal esophageal spasm, but the pressure is really dramatically increased in the esophagus, reaching more than 8,000 mercury per second per centimeter in the setting of normal relaxation of the gastroesophageal junction. Treatment is for both diffuse esophageal spasm and hypercontractile esophagus is PPI twice daily, trial of peppermint oil, short-acting nitrate or calcium channel blocker, and low-dose TCA. Thank you.